So Brady, welcome to Torn. It's good to have you on. Why don't you just go ahead and give me a little bit of your background and maybe why you got interested or how you got interested in treating the ACL population?
Absolutely. So yeah, my name is Brady Solie. I'm a clinician at Training House in Eagan, Minnesota. I've been doing ACL rehab for probably the better half of 7 to 8 years, pretty consistently. My caseload at Training House is probably about 90 to 95% ACL reconstruction. So get a pretty good volume of different age groups and different kind of styles of athletes, general pop, and kind of doing their ACL reconstructions. I guess what really kind of got me into it is, going through physical therapy school and even before that in undergrad, I had some opportunities to kind of be around the rehab setting. And it just so happened that those opportunities were a lot around kind of late phase return to play. And we know just, historically return to play research and kind of that thought has been probably geared more around the ACL. And we probably have the most data kind of around ACL reconstruction, return to play. So early on within my education, just being around some of that return to play stuff, it kind of honed in on the knee. And I kind of got some early exposure to that. And then going into doing residency after PT school, I went down and did residency in Minneapolis
Mhm.
with Fairview Health. And through there, I spent actually a lot of time on the shoulder.
Mhm.
I was trying to learn a little bit more about the shoulder just because I had done so much around the knee and kind of lower
Mhm.
extremity. And then when I got out of residency, I was kind of trying to figure my way between doing some upper extremity rehab and lower body. And I think you just kind of come back to the things that you know and maybe the things that you're
Yeah.
a little bit more exposed and good at. And my clinic started to kind of morph away from doing, bank art repairs and rotator cuff repairs more into the knee. And
Mhm.
it's just kind of continued to morph where really now I see a lot of just, ACL reconstruction throughout the day. So
Yeah, cool. I think that's a good transition into kind of the topic for the day is those return to sport, especially with, ACLs in particular. They're hard. Return rates aren't great, and it's a taxing recovery, long taxing recovery. So that's why I wanted, no better than you to talk about some of these topics that we're going to talk about today as far as like how we can get athletes back, or reduce that percentage of the athletes that are getting back or not getting back, you know what I mean? So let's talk about and break down these five topics here that you kind of came up with as far as, what clinicians can work on or that have trouble with that you see in your clinic as far as, students that you see and where we can kind of, help push and get that percentage to increase with these athletes going back. So the first one that you mentioned is, the preoperative therapy. So getting athletes in prior to surgery and having those conversations with them, working on certain things. Kind of talk me through what is so critical about that.
Well, I think if you look at just the prehab literature in general, we know that the biggest predictor of kind of how you do after surgery is kind of like, what you look like before surgery.
Yeah.
And I think that when you go under, going into doing an ACL reconstruction or going into one of these bigger surgeries that we really know is going to take you a year to rehab, back from, I
Hmm.
think starting with, meeting your therapist, meeting your surgeon, really kind of getting your team around you is really powerful.
Hmm.
And I guess in my eyes, like, what's the alternative to that? Well, say you have, you meet your surgeon, you have this ACL done, and then you show up in a physical therapy clinic maybe the day after surgery, and you're meeting a new face, you're getting all of your rehab information kind of going that day there, and at the same time, you're dealing with high postoperative pain, maybe a little bit of anesthesia still in the system, and
Sure.
I just think it gets to be a lot to digest. So I'm very passionate about trying to meet and see my athletes before they have their surgery.
Hmm.
And the doctors I work with are seeing the value in that too, because it really does. It gives the patient or the athlete a chance to kind of assemble their team. You can run ideas past one another, really set goals, and try to understand each other's kind of perceptions and styles, both from who
Yeah.
you're working with as a therapist, but also who's the patient in front of you and what do I
Right.
need to prepare for to kind of really do the
100%.
best job I can. So I think prehab in general, it's multifactorial the way it can kind of benefit a care plan. But the big things that show up for me is, the rehab planning and the meeting, but also, we talk about graft selection and kind of understanding maybe what type of procedure that athlete's going to have done. That
Hmm.
can help kind of prepare them. We do the quad tendons, a new procedure. Traditionally, we've seen a lot of these hamstring grafts. There's a
Hmm.
big difference in the way that they kind of bounce back having a hamstring graft versus a quad tendon graft. So having those discussions about maybe early quad activation after surgery and kind of getting that stuff going can be super helpful.
When you have, obviously in our clinics and your clinic, the surgeons that you work with are obviously pretty big on that too. Where's like kind of the disconnect with, I don't know, a clinic or a physical therapist that maybe doesn't have a relationship with a surgeon that conversation can be had, or even if the surgeon maybe doesn't prioritize the preoperative therapy as much either. Like where's that kind of, where do we go from there?
Well, as with everything in healthcare, I think it's an education thing. If you
Yeah.
look at the data, and I think a lot of the surgeons do look at the data. I mean, it's pretty good that supports preoperative therapy. I think one thing we run into in America here is, just with the nature of the way we do healthcare, ACL surgery is something that happens fairly quick after an initial consult with the surgeon.
Mhm.
So I think sometimes it takes a back seat to scheduling the surgery and kind of lining up some of the post-op visits with the surgeon, and
Sure.
it can fall through the cracks. So I know in my experience, being transparent and reaching out to surgeons and maybe even discussing cases that you've had a hard time with. I've looking back over the years, I think I've probably had 15 or 20 conversations with surgeons about just cases that I felt like I dropped the ball on, had
Hmm.
a bad, first impression with the patient, or maybe there was some confusion that frustrated the patient and the family, things like that were kind of geared around them coming in and meeting me for
Yeah.
the first time. Those are good teaching points for the team to talk about, and open that dialogue. So if you're a clinician that maybe doesn't work as closely with one surgeon, or maybe you do but you're not kind of talking about those things, I think it starts with opening that dialogue, and maybe it's sneaking into clinic for a couple hours and talking about it, and maybe discussing some of these topics. I mean, most of the docs I work with, I found that if I'm polite, humble, and straightforward, a lot of times I can get good conversations going
Sure.
with that side of the aisle. So
Sure.
approaching those tactfully and kind of knowing what your objective is can be pretty helpful.
Yeah. Yeah, for sure. I think going back to the importance of it too is you mentioned it a little bit of like just understanding the patient and the personality or like the psychology of a patient. At least for me, I've kind of started to understand patterns. Like if I see someone preoperatively, I kind of have a good idea of, 95% of the time, I could probably guess how they're going to do post-op. Not
Hmm.
from, and maybe even a little bit from getting their quad backs, range of motion, some of these other things, but also, what the return to sport timeline is going to look like and what they're going to look like when they return. You have like the contrasting 14 or 15-year-old female athlete, or maybe even male athlete who's a little bit more conservative, or, we've talked about this before, someone who's you termed it like allergic to an ACL reconstruction, where they
Hmm.
just, that they might struggle versus,
Yeah,
the 18-year-old who is, raging with testosterone and they're going to get their quad back and then they're going to push you to get back early. So I think you're right. I think getting seeing them before surgery to have a better understanding of like how you can prepare for any potential conversations you're going to have in the future, I think is important because then, like you said, it sets the standard that you can do this all prior to surgery because there's a lot going on post-op, at least the
yeah,
first initial few days.
absolutely.
Tell me a little bit about like a couple things that you really prioritize pre-op as far as like objectively or physically on the knee itself.
Well, I think that, in my hands, that there's different prehab care plans. I have knees that, the surgeons send over, particularly because they're having range of motion and quad issues going on,
Yeah.
versus other times it's I want one PT session just to kind of learn some exercises and kind of get things going. And
Yep.
I think you really have to begin with kind of understanding what you're trying to do with the case. The person that's got some preoperative, muscle inhibition, motion issues, things like that, you want to be open and communicating that both to the patient and the surgeon and kind of how they're
Hmm.
progressing. And there's been a few cases where I've asked for another couple weeks of prehab just because I know their motion isn't where, we want them. But
Yeah.
in other cases, they're coming in and on the table, they look pretty good. They got full motion, they got good quad, swellings kind of in control there. But
Hmm.
I think it really boils down to kind of addressing, what type of plan that you're going to have prehab, and then, picking exercises and building a program around that. So, for instance, say I have a ACL that's coming in for, a one-time preoperative visit and
Hmm.
I eval them, and again, motion's looking good, swelling's under control, and they got a good quad. I think those sessions are geared towards, what to expect after surgery as far as
Sure.
the exercises I'm going to be giving you, what things I need you to be super proficient in. Even if the quad set looks really good on the table, I'm still taking the time to teach them quad setting, and I want them to kind of do that exercise because I know after surgery, the
Yeah.
surgery is going to knock them down a little bit. And I guess in my hands, the more I've taught those athletes those exercises, I think the better the brain kind of grabs them after surgery
Yeah.
versus, other knees where, maybe I'm just trying to get, flexion and extension and I don't even really get on to isolated quad set training as much.
Sure.
Um, knowing that after surgery, there's going to be motion issues, you have to kind of prioritize, how deep you go. I've
Hmm.
had cases where I'm giving athletes just very global programs like just biking. I want you to bike every day for 20 minutes, and then I want you to do some type of a PNF stretch, flexion
Sure.
extension, whatever it is. And I'm just trying to globally mitigate a big problem for after surgery.
Yeah.
So it's about being able to kind of zoom in and zoom out. And, in some cases we have very micro, detailed oriented home programs for an athlete that's doing
Hmm.
really well prehab versus the next one where we're just trying to mitigate big problems and it's a
More
little bit more
global.
global kind of a program. Yeah.
Yeah. Yeah. Transitioning into that second topic, moving on from the pre to post-operative care, that second thing we talk about or that you mentioned as a big kind of priority is setting the standard for the acute phase. So whether it's the first 6 weeks, the first 8 weeks, the first 12 maybe, why is that phase so critical? And, what are some of the things that you really emphasize in that period of time?
Well, I think when you come out of surgery, just naturally the body's got, a tendency to, kind of shut down, relax. It wants to be still, it wants to avoid pain.
Hmm.
All these primitive kind of reflexes and instincts are kind of coming in there. And I guess in my hands, I know that I need to kind of change the tone of that a little bit. And I think, a lot of times you just got to educate the athlete or the patient that coming out of surgery, it's actually a time to go. That early
Sure.
first couple weeks, I've even had some of my mentors and peers talk about like, hey, if you only have 20 to 30 PT visits, where are you going to burn them?
Yep.
And they burn them on the front end because if you run into motion issues, you run into quad activation issues, it can completely derail the rest of
Absolutely.
their kind of natural recovery of their body. So I think coming out of surgery, you got to be prepared to kind of help manage that athlete and say, hey, actually, I need you to move several times a day. I'm gonna put you on a fairly strict rehab plan. Along with that, we're going to be kicking up some dust and causing some increases in pain. Okay, here's the
Hmm.
tools to succeed for managing our pain, whether it's post-op medications, icing protocols, that type of thing. TENS units have been,
Yeah.
really popular as of lately for kind of managing post-op pain. And then with that, helping them organize their week. And we all know that every patient's week's a little bit different. You could be a high school athlete versus an adult and things like that. But really taking the time to talk about that and say, hey, this is what I'm kind of thinking and what I expect from you. Is this reasonable? And if it's not, let's start to
Yeah.
tweak things to kind of make this go together the best we can. Because again, at the end of the day, we got to have an actionable plan together to kind of move through that phase, and especially the first 2 weeks, the 3 to 4 weeks there with the range of motion and getting the quad going there. It's something that needs to be feasible to do multiple times a day, so it needs to
Sure.
be laid out and talked about.
Yeah, I think one part that you mentioned to that that's important is, which I've found good success with my athletes, is setting the goals together, where they can, like where you're saying, mentioning, is this doable? And then letting them speak. I think, when I first started treating, where I would say, like, this is what I want you to do, like at school, propped up or quad set, whatever it is at school versus at home versus this, and then not maybe give them enough time to kind of either regurgitate what I'm saying or maybe mention of like, hey, this is not doable right after school, but I can get it done here, whatever it might be. So I think that's a very important thing to talk about with the athlete too, because it kind of lets them be a part of the rehab as well and almost puts the accountability away from me a little bit and lets them be accountable too. I always say, and we talked about this, a number of times is, you see them for 60 minutes twice a week. 98% of it is what they're doing on their own. So if you
Mhm.
can let them have the accountability to be a part of that too, I think that's important, wouldn't you say?
Yeah, absolutely. Another thing that kind of comes to mind is, I have things that I'm not going to budge on, and I kind of know what those things are, and I'm transparent about them to the patient. But I also have things that sometimes I'll try to see what I can kind of get
Yeah,
away with as far as instructing and stuff. And if they're giving me pushback and they're saying that that's not reasonable for them, then I'm dropping down to kind of where my hard lines are there, and kind of using that dynamic to kind of decide, what's bare minimum I need from you versus one things that I'd, really like you to do, or it'd be kind of, helpful if you did.
sure.
So having that kind of laid out in your mind, I think can be helpful as a clinician too, because a lot of times I'm going in with a middle of the road type of a rehab program that I've set up, but I have room to fall back if the patient's struggling or not, able to
Mhm.
get X, Y, Z. I have some room to kind of give up there, but there's a spot where I dig my feet in a little bit, and I have tough conversations about that too. So having that, if you want to call it that battlefield, an example of
Yeah,
kind of moving your lines up and down
sure.
uh, with your exercise selection can be sometimes helpful.
Yeah, that's a great way to look at it. There's the non-negotiables and then some things you can be flexible with. What's the detriment to not taking care of that initial phase? So, whether it's range of motion, quad strength, once you get out of that, like let's say the 8 to 10 week period, if you haven't set that foundation from the acute side of things, if a clinician pushes too far forward into the future and hasn't, taken care of the low-hanging fruit in the acute phase, what's the detriment of that or the potential detriment?
Well, it's kind of like the bathtub, analogy where you want to kind of put the cork in the tub before you start filling it up. I
Yeah,
think I
yeah.
think if you leave the post-op phase and you don't have good motion in your knee, you're dealing with some, terminal quad activation issues and or swelling, what happens is you get into these later phases and you might be putting the work and the time in, or the athlete's putting the work and the time in there, but it's not staying in the tub, it's leaking out. And a lot of
Hmm.
times that can show up as, failure to gain strength. Sometimes it shows up as, irritated knees that are getting sore and painful, or
Hmm.
other times it shows up in their biomechanics where the nervous system is just isn't accepting load, and they're not seeing normal biomechanics kind of come back within their limb there. And then you measure it or you check on it, and there's deficits that are just really hard to clean up. So again, I think it's almost like spelling the alphabet. You have to go through
Yeah,
A, B, C to get to D to really do it right there. And I kind of use that analogy in my head as I'm doing
sure.
these rehabs. I try not to skip letters as I go, because in order to get the whole product, I got to get all the letters anyways. And sometimes you end up going back and trying to get them on your own, and or they need to go back to the surgeon and get a surgery or a
Yeah.
cleanup and things like that. So being stepwise can be, I think, helpful.
Yeah, I think to be fair, when I first started treating, you may have felt this too. Um, whether it was from the surgeon, the athlete, a parent, whatever it might be, like if I felt like maybe their initial acute phase was going a little bit too slow, or if I had pressure from them, even if at 10 weeks they still had issues range of motion wise, which is common, that I felt the pressure to like kind of take those steps into the second phase. Now, it's you set the standard, and if you're not there, you're not there, and we're just going to keep harping on this acute phase. But I fell kind of short of that too, where maybe there was a couple things in my early days where I would try and push it a little bit more than I should have, or I wasn't emphasizing the right things. Just from a new grad or someone who's getting into treating the ACLs, talk through a little bit of like you know, the conversations that you have with, the athlete, the parent, or even maybe coaches or surgeons of, this is just where the athlete is, and I'm not going to budge until they're here. That way they can get a little bit more, of a progression down the road that you don't have to take so many setbacks.
Yeah. I mean, I think it starts with, again, the same kind of the preoperative goals where you talk
Yeah.
about, range of motion, quad activation, and swelling.
Yeah.
As you work through those first 3 to 4 weeks, you're going to get a good kind of compass of if their quad's coming back, and if it's
Mhm.
not, how their motion's progressing, what's going on with their swelling there. And again, in a perfect world, those things are all getting better in harmony. But as you recognize, maybe it's a knee extension issue where they're just not getting knee extension as expected. Being transparent about that, because we know as we move forward, especially with some of these cases that really lose knee extension, there's an indication where they might need another cleanup procedure,
Yeah.
things like that. So I try to advise early on, what we're missing or what mark I'm kind of looking at, or key performance indicator I'm kind of checking.
Yeah.
And if we're not hitting that, what's going on with that and what are the ramifications of that? We know that, flexion seems to be a little bit more forgiving than
Hmm.
extension. So explaining that so that the athlete understands kind of how to prioritize those
Sure.
deficits. Or it could be as simple as, you see their quads waking up, they're able to squat and lunge and things like that, but they're on the table, they still have an extension leg on their straight leg raise and their quads not firing, helping them understand that little bit of inhibition there is going to show up in your gait, and you're going to have times you feel instability or maybe like your knees giving out, especially with higher speed movements if that doesn't clean up there. So I think kind of starting with that why when you're explaining what you're seeing can be super powerful for both just, the athlete to understand what's going on, but also as you talk to the family about maybe real complications that are popping up that are changing the course of the rehab.
Yeah, just setting the standard. Yeah, I think
Mhm.
that's an important thing to talk about too is, you know, I think when I was fortunate enough to be, surrounded by some very good clinicians like yourself in my practical side of things or my clinical rotation side, where I would see you had conversations with athletes or parents where, setting that standard, even if it's a hard conversation, I kind of just say this to someone observing me, you have to have that conversation because if you shy away from it or, you're not, in a good spot, I don't know what, you don't feel confident enough to have a conversation with someone older than you or even just an athlete themselves, you're probably predisposing them or setting them up for failure a little bit. So as
Mhm.
much as it's as difficult as it is, it has to be the patient first, mentality because if you shy away from having a conversation with a parent about we're not going to move on until your knee extension is appropriate and you just kind of let that go and go and go and then like you said they do have issues 4 or 5 weeks down the road when they're getting back to higher level movements.
Yeah, absolutely. And I think as you work with people and the more kind of comfortable you get having, honest and sometimes
Yep.
difficult conversations, there might be a little bit of frustration and kickback on the front end of kind of understanding how those conversations go. But in my hands, I've had a lot of athletes that, in one moment they're upset, crying, and maybe we're having a deep discussion with the friends and with the family, and 3 to 4 to 5 months down the road there, we have a really tight, harmonious,
Yeah,
therapeutic alliance because we've done
absolutely.
that. So I think that's, some of those hard conversations are actually the magic of healthcare kind of happening, especially when we talk about therapeutic alliance and kind of getting these athletes to buy in there. You got to go to that level sometimes. And even in the moment, if they don't want to really hear it, I think on the back end, if you're doing a good job of being a healthcare provider, sometimes the patient's almost drawn back to you just naturally because you go there.
Yeah, that's
You
a
know,
great point.
my coworkers always kind of give me a little bit of a hard time, but one of my favorite statements is, I care.
Yeah.
And sometimes when I'm having a tough conversation, whether it's about a failure to comply with what I want going on or a struggle we're having in rehab, there's always a moment where I kind of pause and say, I'm saying this or I'm being a little tough on you because I care. And
Hmm.
I truly believe that's the God's awesome, honest reason that I'm doing that is I think that conversation is that important to really get the very best outcome for their knee or their injury.
Yeah. Yeah, that's a great point. Moving on to the third thing we talked about. You mentioned not treating the athlete. So a little bit of like we have timelines, protocols, certain standards that we want to talk about or see in an athlete, but we kind of maybe misalign, not treating who the athlete is themselves, personality or psychologically. Go into a little bit more depth on that one.
Yeah, I think the most common example I think of that is just like even some of these athletes that are moving a little bit faster and a little bit slower. Us as clinicians and healthcare providers, we're always juggling a few different pieces of information. And I think when I make shared decisions with either my teammates at training house or the parents or the athlete, I'm trying to prioritize what's really important as they move forward. Like for instance, now I have a high level athlete that had a meniscus repair, and I know she's on an accelerated timeline. And whether I like it or not, this athlete's going to be going back to play on a kind of an abbreviated return to play plan.
Hmm.
So I have my biological considerations and my functional considerations and patient values I'm kind of going through. And in this case, I'm actually kind of pushing some of the loading a little bit, quicker than I would maybe like to. Number one, because she's responding well to it and the knee's not swelling up and things like that. But number two is I'm trying to take the ideal rehab plan and condense it a little bit. And
Hmm.
I'm not doing her any favors by delaying some of that loading for later on because she's just gonna, set up her up for failure when she kind of goes back to play there. So even though the meniscal healing might be a little bit on the front end, I'm doing a little bit of the loading as I can, and then I'm checking to see if it's tolerated at the joint there, with the goal again of kind of getting her back to play a little bit quicker, knowing that that's going to happen whether I like it or not. So again, kind of seeing those cases, kind of getting the big picture with the app sometimes helps augment some of your loading and some of the decisions you make versus the next athlete that you're going to need to slow down and you have time on. Um,
Hmm.
Sometimes, even if the knee's looking good, I'll kick the can down the road a couple more
Yeah.
weeks just to kind of make sure I'm spreading out the loading and I'm not having any, flare ups that really don't need to happen. So
Yeah.
I think that's the big thing with those cases is you gotta realize the horizon and maybe take that 5,000 foot view of what's actually happening with the case.
Yeah, I think that's a great point too. You also need to look at, and I always have this conversation with my athletes too, is timeline wise, it doesn't, if we can, like you said, maybe extend it a few weeks. I don't maybe always necessarily say that out loud, but just in my head, where if they bring it up, sure, I'll have that conversation with them. But for example, I have an athlete who is wanting to get back to soccer and she's, 10, 11 months out. And she doesn't start until April or May. So in my eyes, I'm like, okay, how can I kind of still emphasize and prioritize some of these things because I have the luxury of doing that versus, maybe she's probably ready to go back and do some training sessions, modified, whatever it might be. But do I have the capacity to kind of, delay that a little bit? I think those are insanely important things for a clinician to think about because if it's structured where it's 9 months no matter what, that kind of, you might be setting an athlete up for failure or, maybe not, maybe they could go a little bit earlier, like you said with that athlete, versus it just being, okay, 9 months, here it is. Maybe it's 14 months for somebody or, 8.5 months for somebody else. So I think as clinicians, you kind of have to take all these different facets of, what the athlete is, what their sport is, and even to be fair, even what the position they play. I have
Mhm.
this conversation with baseball players, for example, versus, a football player. Someone who is a first baseman, maybe they have the capacity to go back at 8 months versus, and we can modify like pinch hitting, those types of things versus you're a running back. That's much different where you have to display very, very certain, level one sport movements that just aren't as required in some of these other sports. Fair
Mhm.
enough.
Yeah, I mean, in hearing you talk about that, I think you did a great job of kind of explaining that, Mark. But my thought was, when I have time, my job is to not make silly mistakes.
Yep,
When I don't
absolutely.
have time, I want to make sure that I take very calculated risks. You know what I mean?
Absolutely.
So if I'm going to push something forward and I know it's, not ideal and maybe is a little bit risky, let's run some math on that, make sure that that's a calculated risk that we're taking.
Hmm.
Versus when I have the luxury of time and I know I'm not under any pressure, my job is to not make any silly mistakes. Don't flare the knee up. Make sure everything's structured. Take the time to organize things thoroughly. I
Hmm.
think that saves you a lot of heartburn in the long run.
Yeah, I think it's a great point where yeah, just trying to figure out who the athlete is and where they are timeline wise and just getting a better understanding of all that versus so structured, which, maybe as a new clinician, maybe you or I definitely felt that myself where it was like, yeah, 9 months is the target point and that's where we want to
Mhm.
get to versus, maybe there's fluctuations on both ends. Talk a little bit, I think that's probably a good time to talk. I want to talk a little bit about like different patterns that you see. I know we talked a little bit about it earlier, patterns personality wise or psychologically that you've noticed over your time treating ACLs that you can kind of have like these, I don't know, predisposed notions of pre-op or even as someone's going through the rehab of, like you said, treating the athlete, who they are physically, mentally, psychologically, personality wise, where it's like maybe I need to push this person a little bit more, or maybe I need to step back and let this person kind of do things a little bit more on their own time. Because I have, there's certain athletes, like you mentioned, ones who maybe tear up a little bit more. Like, how do you kind of cater toward their personality versus someone you need to, kind of hold back or push? Talk that a little bit about that, because that's such a huge part of the rehab too.
Yeah. I mean, we have some hard data on kind of some of those clinical trajectories based on kind of like the ACL, RSI, and things like that.
Yeah,
But there's a little bit of an art that goes into that too, because
100%.
there's constantly intervening variables on every case. I even think about, I have a gal right now who's what I would call my typical kind of person that's going to have a hard time, which is,
Yeah,
a softer affect female,
sure.
first time getting hurt, playing a sport like a volleyball or even maybe soccer a little bit, where it's just not a crazy intense like uh, junky sport where you're just dealing with fight to the pain at all time.
Sure.
And I feel like even with those cases, like as I work with athletes, sometimes I get the wrong read on some of those girls. And with my education and things like that, I've seen some of those girls I'm really worried about come out and just kick butt just by the way they respond to the cueing and
Yeah,
the demand to step up that I give them. Versus the next girl, if you're talking to an athlete and you can tell that you're kind of losing their concentration a little bit and maybe they're in a little bit of a denial state, well,
hmm,
not really taking in the education there, those are the ones that you're like, this might be a long road, and even looping the family in on some of that stuff. So you get little clinical trends like that.
hmm.
The other one that pops to mind is again my football boys, rugby, uh, even lacrosse, things like that. These sports that are a little bit more violent in nature.
Yeah,
Some of those
wrestling.
guys, they tear their ACL, and you meet them, and you can tell like it didn't phase them at all.
Yeah,
They're not psychologically rattled about having surgery. It's no big deal. Even a little bit of a God complex or whatever
hmm,
it is. You
sure.
don't worry about those athletes. They're gonna come back and get their leg back and get their performance back. What I worry more about with them is their risk taking behavior with their
Yeah,
return to plays, where it's like
yeah,
these are the ones where it's like, God, you actually have a symmetrically strong quad. Are you gonna pop your ACL graft right away because you're gonna
sure.
go balls to the walls the
Yeah.
first practice back there? So there's a lot of personality traits and kind of individualized, psychosocial components that really set these athletes up for either doing well or kind of giving you gray hairs.
Yeah, and even at certain periods throughout the rehab, like the ones who are going to push you are probably going to be the ones you have to kind of constrain a little
Mhm.
bit more toward the end versus the more conservative or
Yeah,
apprehensive ones. It's going to be more of like the acute stage, and then they end up doing okay over at the end stage.
yeah.
Yeah, talk a
Something
little bit
something
about some. Yeah, go ahead.
I was gonna say something, that you look at the literature too, and some of it's, with hamstring grafts, sometimes it's with other grafts, but the athletes that sometimes you really worry about are the ones that are high performers early.
Yeah, right.
These athletes that are coming out, they're 6 months out, they're 8 months out, they got symmetrical quads, they got, really relatively good strength in their legs, their counter movement jumps look really good. I actually worry
Hmm.
more about those athletes sometimes because number one, they tend to be a little bit better athletes, but number two, they have the force profiles needed to rupture their ACL.
Yeah,
A lot of times it's almost like the analogy with the hamstring strain, like slow athletes don't strain their hamstrings as much as fast athletes do. You
yeah,
know what I
that's a
mean?
great
You
point.
need you need force, and some of these athletes that come out swinging and they got really good performance early on, those are the ones that you actually worry about. We know that the ACL graft, takes an upwards of 2 years in some
Yeah.
cases to fully integrate, and even sending them back at 9 months, there's still some healing that's going on, and those high performers can be the ones that kind of keep you up at night.
Well, it also might be one of the reasons why they tore in the first place.
Yeah,
Those.
yeah.
Moving into that a little bit, number four, you talked a little bit about like athletic development and kind of having an understanding of where someone is athletically and how to progress, what to focus on, what not to focus on too much. Kind of talk a little bit about what you mean by that.
Well, in my head, when I look at an ACL rehab, I kind of have my motor control bucket of kind
Yeah.
of, athletic movement and kind of development there. And then I have my kind of impairment and capacity bucket. So for instance, like if I look at my, capacities, what am I trying to get better? Usually that's, quad strength, offloading, things like that, that are, kind of, one time point, power movements, strength movements, whatever it
Mhm.
is. But there's another side to ACL rehab that is the neuromuscular, the motor control, and kind of the cognitive load side of it. And I think sometimes when we look at our ACL rehabs, we know we have such a hard time um, getting some of these capacities back. You think about like a quad tendon graft, ACL reconstruction. That's a full 9 months of really strict programming, doing
Yeah.
it very well to really get that quad strength back. And I think sometimes when you're, short on time with athletes, you zoom in on that and you're like, okay, I got to continue to work strength, 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 and you kind of neglect some of the motor control stuff that we know is really goes
Yeah.
into protecting these athletes.
Hmm.
So I think you need to be able to kind of zoom out and really understand athletic development. And in some cases, these return to plays aren't going to be ideal where everybody gets back with perfect performance and
Yeah.
capacities. We got to make sure that we're doing things on the other side of the aisle to, improve cognitive loading or improve frontal plane
Hmm.
mechanics the best we can. Even though we know that there's compensations there, some of those compensations with loading can actually be protective compensations.
Yeah.
So as I work through a rehab, I know that rarely I'm going to have a perfect ACL rehab, and I'm always bebopping to and fro that motor control side of things and that strength side of things, trying to find some level of marriage there as we move
Yeah.
forward versus maybe the next clinician that's like, okay, the first 5 to 7 months of the ACL rehab, I'm just going to work strength
Yeah.
all the time. What's going to happen is you're going to end up with a strong athlete that's got really kind of robotic and kind of poor motor control strategies because you didn't
100%.
expose them. It's the same thing we see with return to running. If you delay return to running, the longer you delay it, the more rigid and kind of suboptimal fluidity you kind
Mhm.
of get with these running postures. I'm a big fan of, as it makes sense therapeutically, finding drills and patterns to kind of get these athletes into. So maybe even they're not running, cleanly, and maybe their strength's a little bit low still. They're still learning to communicate these multi-segmental movements, to try to kind of clean up some of that communication between the different body parts, so that when they actually start cutting, pivoting, and twisting, they got a little bit of, a base of neural learning going.
I think that's such a great point because if you like obviously strength is important, right?
Hmm.
But to be able to adapt and say, let's try things that are safe, but maybe allows someone who's a little bit more apprehensive to load or to do some of these movement patterns to just kind of get reps. I mean, I have a case right now for a girl who is, smaller, just not being able to get quad strength back. And then, being able to start, I started some, puddle steps or some single leg hopping, very, very small load. And then over a few weeks, you start seeing actually a huge adaptation. So
Hmm.
I think there's a massive part to be said about that, that it's not so rigid that even
Hmm.
like you said, someone who is maybe not as strong, there's still certain things you can do that are very appropriate that might actually kind of give that a little bit of an acceleration to the muscle or to the, neuromuscular side of things that kind of almost allows that athlete to take off. I think another part of that too is just from a neuromuscular control standpoint, it's just like the repetition of being able to do it early and then being able to
Hmm.
do that same movement because it's so important. Some of these standard movements, like a puddle step or being able to land soft into a single leg, it just translates so well to movements that you have to do 10, 11, 12 months out when you're actually returning. So
Yeah.
being able to get the body aware of those movements and certain, you know, I don't know, metrics to hit or biomechanical changes that you want to see, starting that early on, appropriately enough, obviously, but
Mhm.
getting them kind of used to that. And maybe even like some case, like you said, someone who's maybe not as strong, having that adaptation early can actually accelerate the process a little bit.
Yeah. And I'm a big analogy guy, but the other one that kind of comes to mind is I had one of my mentors talk about the garden hose outside in the winter.
Yeah.
And if it's 20 below or 10 below out here in Minnesota, and you have a garden hose out there, imagine a hose that's got a little bit of water running out of the end versus the hose that's the valve's completely shut off.
Yeah.
The hose that's got a little bit of water coming out the end, it might freeze up a little bit, but usually there's a little bit of a trickle that kind of
Hmm.
stays coming through so it doesn't completely freeze up. If you shut the valve off completely, you're going to have ice, frozen up in that hose. So
Yep.
that's kind of my analogy is I like to try to keep a little bit of water flowing through the hose as I can because it prevents an absolute freeze up. If it completely freezes up, then you got to start from scratch and thaw that hose out to kind of get water coming back out
Yeah,
of
you
it. But
take steps back.
Yeah, but if you keep a trickle going, sometimes you turn the water back on there, it'll just kind of blow back through, and
Great
you'll be able to
analogy.
get a nice stream again.
Yeah, that's a great point. Leading into number five here, we talk a little bit about, the return to timeline standpoint. Your last point is 9 months should not be necessarily the gold standard, and then you just go straight to return to sport from there. Talk about the importance of still, one, maintaining that relationship with the athlete, and two, still having, there's so many things that you still need to work on once someone hits 9 months and is technically objectively objectively cleared, but what's that, maybe the next 2 to 3 or 2 to 6 months progression look like, and why is it so important?
Yeah, I mean, a lot of the literature now is talking about continuums, and I think it's a great conversation to have because I think we need to get rid of these kind of like cut point, hard stop type things, whether it's with performance testing or with what we're doing with, our loading and things like that. Because
Hmm.
it creates this sense of like I'm waiting for this time point and then I go. Whether it's running, like I'm waiting to 3 months and then I go. Cutting, I'm waiting till 6 months and then I go.
Right.
Like I like the continuum model because it allows you to kind of blend these things in and out, and that's really what we were kind of seeing with the return to play continuum, where you're going back to practice and then you're gonna kind of getting into competition, and really the last thing that tends to come back is your on-field performance,
Hmm.
and it's no different for the knee when we talk about strength training and kind of the performance of the knee. We know 9 months is not enough time to get the stretch shortening cycle normalized within the extensor mechanism after a patellar
Hmm.
tendon graft harvest. It's just not enough time. So by having that 9 month cut point, it creates this illusion that, oh, I just need to rehab hard for 9 months and then I can just go back. I think that's a mistake. You really want to kind of have that athlete on a continuum where it's like, hey, I'm blending you back into play, but I really need you to continue doing some of these rehab based strength and conditioning programs or plyometric programs to really optimize your performance. And that's where some of the performance testing can be very helpful, where you set another test down the road to kind of see if
Yeah.
we're kind of achieving these goals. But really, you have to have a system where, you have these checks built in with the testing and you have the plan in between there. So they're doing a program, they're doing a plan, then you got to check. You're doing a program, you're doing a plan, you have a check. And the check serves as a kind of a compliance indicator, but also gives them feedback, positive or negative, as to if they're going in the direction that you want.
Yeah.
So, in my hands, I have a lot of athletes that go or start their return to practice progressions fairly early, sometimes, 6 to 7 to 8 months after ACL
Hmm.
reconstruction in a level one athlete.
Hmm.
But their long return to play plans, competition minutes are spread out over the course of a few months there. And that whole time, I'm continually asking them to come check in with me. Maybe it's for a PT session or a small group session, but I want them to continue to load as I'm kind of building them back up into unrestricted sports participation, because I think it helps paint a picture of, hey, I can still be playing and still be rehabbing as well, and continuing to try
Yeah.
to really optimize all the work that I put in, versus having again that model where it's like, okay, we'll go back at 9 months when the doctor says I can go back. That's when I go back, and it's almost like they just disappear from the
Yeah.
rehab clinic. That can be sometimes a big problem for secondary injuries and just them failing to thrive when they get back to their sport.
Yeah. Yeah. I think we've kind of gone, from maybe we didn't have enough return to sport criteria, and now we're almost getting to the point where we focus a little bit too much on those objective criteria where you lose like the concept of being able to adapt. And I think
Mm-hmm.
that's, for clinicians starting out or just treating, that's such an important tool to have, is to be able to adapt and not
Mm-hmm.
everything be so structured to where it's, having that conversation. It's going to be 9 months. That's the gold standard, based off of, research and, the
Mm-hmm.
JOSPT article that came out in, was it 2020 or whatever it was? But and I always make this case with or this conversation with my athletes is that can go slightly before or it can go 2 to 3 to 4 months afterwards. It's
Yeah.
never you're getting to 9 months and that's when you're good to go back on the field or the whatever it is. So I think that's setting the standard even, to some degree even preoperatively. I think that's helpful for them to say like this is what I have to hit or this is what my expectations are at 9, but also knowing what marker, Brady or whoever it said, like this could be a little bit longer than that too. So I think
Mm-hmm.
it's trying to find, we have all this objective, criteria that we want to hit and all this new, you know, um, I don't know, all these different metrics that we use, whether it's, Biodex or some of the stuff that we're doing in the lab and, motion capture and all these things. But then we see that. But I also have athletes that, look very good objectively, but I know they're not ready. Whether
Hmm.
it's psychologically or even just their movement patterns, I'm just like, they're not there yet. So I think,
Hmm.
like you said, going off a continuum based, approach versus 9 months, this is it. I think you're setting them up for some failure if you have that approach going into it.
Yeah. And again, it's open dialogue. We talk about, prehab and early rehab, like lay out the ideal rehab plan. That's something
Yeah,
I'm really passionate about.
100%.
Is like have an ideal rehab plan in your mind, but also let the patients know that, you need to take a liberty on that and say, hey, as things roll forward, I'm going to be probably advising differently, you
Hmm.
know. And then the other thing is shared decision making. Like I'm never a dictator with my patients. I
Yeah, great
I
point.
appreciate the team that's around me, the doctors, the athletic trainers, performance staff, and the patients and the families' values too. And we're always in these kind of shared decision type conversations. And I give strong opinions and my beliefs on things. But at the end of the day, like it's ultimately their care plan, and I try to let them have some autonomy in what's happening with these return to plays as well.
Hmm. Hmm. Yeah, great point. Just to wrap up here, Brady, very insightful, man. We appreciate you coming on. I think those five kind of realistic topics that every clinician can kind of hit, I think are very important for, reducing or increasing the likelihood that these athletes get back to sport. Because I think if you're not hitting these five, main points, you're probably setting that athlete up for some, lack of success down the road too. So, anything else you want to add? Maybe some tips or other things that you've come across with students that you've had that maybe some other tips that you want to kind of lay across the way for those guys coming in.
Yeah, I mean, I think the big thing is if you're, whether you're rehabbing ACLs or another injury or a different population, understand your work environment and what you're doing, what are these diagnoses coming through, and do your best to develop a theoretical system.
Yeah.
I'm a big believer in that. Is a lot of times when I'm in clinic, I'm just kind of running the system that I kind of believe in and I set forth. And when I'm doing that, I'm making adjustments to it as I go. But what I find is if I kind of have a system flowing of the loading that I'm doing and the advice that I'm giving, a lot of times they fall in line and they're able to kind of achieve some of these goals. If you hang a goal out there, but you don't have a system in place to kind of really achieve that goal, we know time and time again we're going to miss the mark there. So having that understanding of, whether it's an outpatient rehab setting or you're with a team, or maybe it's in a college setting where you're working with some other health professionals, whatever it is, understand the constraints of what you're working under and what population you're working with. Build a little bit of a system based on theory and what you guys believe in, and run that system, and then check. Have your performance testing, have your other follow-ups kind of going on in there, and see how things are going. And as you identify deficits, go back, tweak your system, adjust, and kind of do what you can. And I think that's helped me a ton get to where I am with as a health professional. You shadow me in clinic a lot of times. I'm just running a system that I believe in, and especially with the ACL population, it's amazing how you can have completely different people, but do loading in a very similar way, and then vice versa.
Yeah.
Sometimes you need to break from that and adjust things. So have that kind of compass in your head of how you need to adjust things as you go.
Yeah. Amazing. That's an amazing point. Just because of the fact that if you don't have that system, you're going to kind of be all over the place with every different athlete and kind of
Hmm.
finding, one, the system, but like you said, being able to adapt to it.
Hmm.
So,
Absolutely.
ready. Much appreciated, man. Thanks for coming on.
Okay. Take care.
Much appreciated.
Thank you.
Thanks for watching. If you're a physical therapist or other medical professional looking to elevate your ACL rehab practice, visit tornuniversity.com and book a one-on-one consultation where you can speak with me directly about any specific challenges you may face and fine-tune your approach to ACLs. Also, be sure to check out my monthly webinar series where I dive deeper into ACL-related topics designed and shaped by your specific needs and questions. Don't forget to like, subscribe, hit that notification button for more content, interviews, and more. Follow me on social media at Torn University for more daily ACL related topics. And as always, drop any comments or questions you may have about ACLs, and I'll catch you guys in the next video.